Medicaid and the Governor's Office of Health Transformation. This is Karen Hoyt. I direct payment innovation activities for the Ohio Department of Medicaid. In this session today, we are going to provide an introduction to Ohio's Episodes of Care model. Before diving into the model itself, we'd like to share background on Ohio's approach to paying for value versus volume. The chart here highlights the case for change in Ohio and the rationale for the shift to pay for value. As you can see from the highlighted bar on the page, Ohio spends more per person on health care than all but 17 states. But Ohio has a less healthier workforce than 36 other states. Ohio's approach to pay for value includes the design and implementation of two models, episode-based payments and our comprehensive primary care program. I'll start with a brief update on Ohio's CPC program, given the focus of this presentation is episode-based payments. Over the past year, we've been working to design the care model and the payment model targeting coverage of 80% of Ohio's population. A statewide provider survey with over 500 responses from Ohio providers was used to gauge readiness. There's an infrastructure plan in place for attribution of members to providers, provider enrollment, scoring, reporting, and payment. And additionally, we've been working with a number of stakeholders to design CPC performance reports that will be shared with all enrolled Ohio CPC practices. Now turning to the episode side, we've designed 13 episodes to date and have an additional 30 planned for launch in 2017. 9 different payers are releasing performance reports for Wave 1 episodes. Additionally, for the Medicaid program, 3 of the initial Wave 1 episodes are linked to payment. For Wave 2, the state is now releasing performance reports with aggregate information across all Medicaid managed care plans and fee-for-service. As I mentioned at the beginning of the presentation, the goal here is to walk through the episode-based payment model. The Ohio episode model is a retrospective model, not prospective. To repeat, there is not preset price for a bundle in the retrospective model. The top of this page highlights what stays the same. Patients continue to seek care from providers of their choice. Providers bill and are reimbursed as they are today through the fee-for-service model. The bottom of this page illustrates how episodes are identified through claims data. After the fact, claims data is analyzed to identify the principal accountable provider, or PAP, who is held accountable for all episode costs, not just those he or she is directly billing for. All episodes attributed to a specific PAP are risk adjusted, and then the average episode cost per PAP is calculated. The PAP's risk-adjusted average cost is then compared to a set of thresholds. Some PAPs will receive a positive incentive payment if they are below the commendable threshold and have met specific quality metrics. Others may incur a negative incentive. And many of the PAPs will see no impact if the average cost is between the commendable and acceptable thresholds. Let's walk through this chart to understand how the performance assessment works in the retrospective episode model. There is one bar for each principal accountable provider. The height of the bar represents the PAP's average episode cost across all their episodes in a given time frame. After adjustments have been applied, such as risk adjustment and removal of high-cost outliers and other exclusions. The bars are ordered from left to right, from the PAP with the highest average episode cost to the PAP with the lowest average episode cost. If a PAP's average cost is above a preset acceptable threshold, those in red on the left-hand side, they may be at risk and pay back some of the cost to the payer. If a PAP's average cost is below a preset commendable threshold, those in green on the right-hand side, they may share in the savings. Note that the PAPs shown in blue here have an average cost below the commendable threshold. However, they are not eligible for positive incentive payment because they did not pass quality measures. Here are the core elements of the episode definition. This structure is used to develop the definition of each episode. The episode trigger is the logic and set of procedure and/or diagnoses codes that define an episode. The episode window represents the duration of the episode. We typically divide the episode window into 3 distinct time frames because the claims included in each window differ. The pre-trigger window is a set of time prior to the episode trigger. Typical services included maybe relevant testing or screening prior to a given procedure. Note that not all episodes have a pre-trigger window. The trigger represents the duration of the potential trigger event, which is typically a single day or length of stay in an admission if the admission is the trigger. All care is included in the trigger window. The post-trigger window represents a specific duration, for example, 30 days, during which relevant care and complications are included. The next element is the Principal Accountable Provider, or PAP. This is the provider who is in the best position to assume principal accountability in the episode based on factors such as decision-making responsibility, influence over other providers, and portion of episode spend. Associated with each episode are a set of quality measures used to ensure high quality of care is delivered in an episode. A select set of the quality measures are linked to the positive incentive payment, meaning that a PAP with an average risk-adjusted cost below the commendable threshold must pass those measures to qualify for a positive incentive payment. There's also a specific risk adjustment model for each episode. The risk factors are determined through a linear regression model that looks at the presence of risk factors and correlation to episode spend. In addition to the risk adjustment model, there are a number of business and clinical exclusions. Clinical exclusions represent patient characteristics, comorbidities, diagnoses, or procedures that due to complexity or cost should be removed from the calculation of a PAP's average cost rather than adjusted. The episode definitions were developed with input from a number of providers and are also informed by rigorous claims data analytics. Now we'll walk through a specific episode example, perinatal. Perinatal was designed in our first wave of episodes. The episode trigger is the delivery procedure code with a confirmatory live birth diagnosis on any claim type. The pre-trigger window begins 280 days before delivery and ends on the day before delivery. During this time, all relevant prenatal care and complications are included in the episode spend calculation. The trigger window is the day of admission to the day of discharge, and all spend related to the care for the mother is included here. The post-trigger window begins on the day after discharge and extends for 60 days. Relevant care and complications, including readmissions that again are related to the delivery, are included in the spend associated with the post-trigger window. The PAP is the physician or physician group responsible for the delivery. We identify PAP at the billing provider level, so it is the billing or contracting entity. You can see the list of quality measures here, or linked to a positive incentive payment, and they include rate of specific prenatal screening, C-section rate, and percent of episodes with a follow-up visit within 60 days. Over the next few pages, I'll walk through an analysis that shares additional details on the risk factors and exclusions. The first step in the episode model is to identify all potential episodes of care and attribute them to a principal accountable provider. Included here is the non-risk adjusted PAP curve for perinatal. This is prior to the removal of any exclusions. There are a series of bars stacked next to one another, and each bar represents a single PAP. And again, the height of the bar, in this case, is the unadjusted cost per episode. Next, we apply a set of exclusions. As I mentioned, there are both business and clinical exclusions for the model. You can see the business exclusions listed here. The bulk of these are consistent across all Ohio episodes of care. A few examples include dual eligibility or inconsistent enrollment. In both of these cases, the claims included in the Medicaid data set do not represent the full picture of episode spend, and hence, these episodes are excluded. The box on the right-hand side shows the list of clinical exclusions for perinatal. A number of these, such as active management of cancer and end-stage renal disease, are also consistent across all episodes. Others, such as age and some of the pregnancy or delivery-related diagnoses, are specific to perinatal. For each episode, there are a set of standard as well as episode-specific exclusions. Additionally, as you can see on the bottom here, we also normalize any inpatient spend to remove the impact from medical education and capital expenses. On the chart here, the gray bars refer to original TAP curve prior to the impact of exclusions and normalization. The navy bars represent the average spend for the same TAP after business exclusions and clinical exclusions are removed, and inpatient costs were normalized to remove the impact of medical education and capital expenditures. You'll see for most TAPs, average episode costs decrease. For some TAPs, however, average episode costs may increase due to the removal of low-cost business exclusions, such as episodes with incomplete claims, due to some of the examples I mentioned previously, like inconsistent enrollment. Additionally, each episode is risk adjusted. The risk adjustment model for perinatal accounts for more than 70 risk factors, a subset of which are shown here. As a final step, once risk adjustment is applied, high-cost outliers that are more than 3 standard deviations from the risk-adjusted mean are also removed to prevent episodes that represent outliers in terms of spend from unfairly driving up a TAP's average risk-adjusted episode cost. This chart shows the original TAPs in the same location with the original unadjusted spend prior to exclusions in gray, just as you saw in the last chart we looked at. Here the navy bars show the average risk-adjusted reimbursement per episode. As you can see, the risk adjustment process risk adjusts down the episode spend to the level of a low-risk episode. This is something we want to call out because it is different than the way many people think about risk adjustment. If you're interested in additional details on the risk adjustment model, there's a white paper linked to the Department of Medicaid's Payment Innovation website. On the top chart here, the navy bars from the prior page have been reordered from largest to smallest. This is the risk-adjusted TAP curve. Below that is a chart showing the average degree of risk adjustment with the TAPs in the same order as the top figure. As you can see, there's no correlation between average risk adjustment reimbursement and level of risk. Again, what you see here is the risk-adjusted TAP curve. Overlaid are some quality metric statistics for the 10% highest and lowest cost TAPs. You can see the C-section rate varies from 37% for the 10% highest cost providers after risk adjustment to 20% for the lowest 10% of providers. The average number of ultrasounds per episode is approximately 5 and 3, respectively, for the high and low cost TAPs. When we look at follow-up rate visit, you can see performance there is comparable on both sides of the curve. Here's an example of the report that's currently being delivered to all TAPs for Wave 1 and Wave 2 episodes in Ohio. At the top of the report is a set of eligibility requirements to help explain how volume, spend, and quality metric performance impacts a TAP's eligibility for positive and negative incentive payments. At this point, Medicaid has only linked 3 episodes to payment: asthma acute exacerbation, COPD exacerbation, and perinatal. For those 3 episodes, providers will see the TAP curve colored as it is here, and with thresholds drawn over top of the figure at the specific threshold values. Thresholds are also posted on the Medicaid website. Complementing reports is a CSV file that includes information on both valid and excluded episodes ending during that reporting cycle. These files are a tool to help providers understand key sources of variation. For example, you can use this file to look at the breakdown of average risk-adjusted spend by rendering provider. You can also look at the impact of specific services, for example, inpatient or pharmacy spend. And they contain quality metric performance for each episode as well. For Wave 1 and Wave 2 episodes, the Medicaid website currently includes a number of resources and detailed documents regarding the specifics of each episode. As we look toward episode design for Wave 3 this year, the website will continue to be a place where Ohio shares detailed episode-specific documents. Materials for Wave 3 episodes will be posted in late 2016 or early 2017. Now to turn to additional details on episode design for 2016. Here's the timeline for episodes across all waves moving forward. For Wave 1, the episodes were designed in 2014, reported on all through 2015, and now 3 of the 6 are linked to payment for the Medicaid program. For Wave 2, we just began the reporting-only period for the first reports delivered at the end of April or beginning of May. Wave 3 design is occurring this year, and you'll see a number of episodes listed. Episode design is accelerating over the next 6 to 9 months, and we will share more details about that process on the following pages. Given all of the progress on the episode side to date, we think we have a real opportunity to accelerate episode design and reporting in tandem with Ohio CPC launch. Operational changes, like the fact that Medicaid is reporting for Wave 2 episodes for the entire Medicaid program, including the managed care plans, enables the shift from the steady state of designing approximately 7 episodes a year to pulling design forward and reporting on more episodes in 2017. We know that doing this effectively means continuing to adhere to guiding principles like leveraging decisions from our prior waves, as well as other programs in flight, and transparently sharing all details of design, while also innovating on the design approach, including the way we seek provider input. Our accelerated CAG 2.0 approach leverages the work done to date with all of you and is designed to be responsive to provider feedback regarding cumbersome midday in-person meetings while continuing to get Ohio-specific input critical to our model. Accelerating the process will allow us to realize projected impact earlier, and it creates scale efficiencies, creating option value to do additional activities through our SIM work. Prior to looking over the list of episodes planned for 2016, we wanted to take a step back and review the 6 archetypes we consider for episode design. I think most tend to associate episodes with planned procedures, but as many of you know, we've already designed episodes related to acute emergent conditions, such as asthma exacerbation, acute non-emergent conditions like URI, and as we look toward 2016, we'll be adding chronic conditions like ADHD as well. These 6 archetypes encompass the conditions and indications we consider episodable. The archetypes also tend to be associated with specific paths or sources of value. For example, chronic conditions, the path is often the provider the patient sees most frequently for related care, while for an acute emergent or non-emergent condition, it's the provider first seen for care. As we look across planned episodes for 2016, as well as Wave 1 and 2 episodes already in place, they span all 6 archetypes. I'll give you a minute here to read through the list. A subset of the Wave 3 episodes will be designed through a CAG 2.0 approach. For these episodes, we are collecting recommendations for provider experts statewide to participate in the episode design process prior to the launch of reporting. The next page includes additional details on this process. Listed here are the key components of the CAG 2.0 approach. Ideally, each CAG 2.0 will involve 15 to 30 clinicians, similar in size to our prior clinical advisory group. As has been the protocol in the past, we're seeking recommendations from a variety of sources, including providers that have participated in other design groups, our payer partners, and other related clinical organizations. Recognizing that many of you will be new to the process, we're encouraging review of this webinar, which is posted online. For each episode, there will be a brief concept paper summarizing design, as well as a set of key questions. While for CAG 2.0, this paper will be used to solicit input, it will be developed for all episodes to act as an intermediate between the roughly 2-page definitions currently posted for Waves 1 and 2 and the very detailed business requirements document. In addition to the introductory webinar, once materials are delivered to the providers, there will be a call for any clarifying questions. Clinicians will be given approximately 3 weeks to review the materials and provide feedback through a structured template. Following collection of this feedback, on an as-needed basis, there may be targeted focus groups or interviews. Once the feedback has been reviewed, updates will be made to the definition as appropriate, and then an updated concept paper will be shared back with the CAG 2.0 participants in the 4 to 6 weeks following the review period. Lastly, in addition to the Medicaid website that has already been shared, we would encourage you to visit the Governor's Office of Health Transformation website for additional resources. Several presentations and documents from SIM overviews to detailed design documents on both CPC and the episode model are posted here. We very much appreciate you taking the time to watch this webinar. We know many of you have busy schedules and hope that the online availability of the presentation is helpful. Thank you very much.